All right. Good afternoon, everybody. Thank you for spending your Friday afternoon, Friday evening with us. This is our next installation of Academia SG's Junior Scholar Seminar. We are really happy today to have a great speaker and a great discussant. We only are going on for hours, so I won't be too long on this. Today, our speaker is Rayner Tan, who's a postdoctoral fellow at the Swee Hock School of Public Health at the National University of Singapore. He was previously trained in sociology at the Singapore Management University, and his work looks at the intersection of health, gender, and deviance. Now, our discussant today is Travis Kong, Associate Professor of Sociology at the University of Hong Kong. He has action-oriented and interdisciplinary approach to research on homosexuality and masculinity in China, commercial sex in Hong Kong and China, looking at the social impact of HIV/AIDS, transnational Chinese sexuality. So these issues largely motivate his teaching in gender and sexuality studies, as well as media and cultural studies at Hong Kong U. And today what we're talking about is sexualized substance use, or Chemsex, in the male gay community. Now, those of you in Singapore might have seen this come up in the news. A lot of it surrounds ideas of criminalization, homophobia, what is legal, illegal, things like that, and of course 377A. Now, what we're going to try to do today is Rayner will bring us to sort of look at some of the sort of background to this. Why do people engage in this sort of activity? What motivates them, and the sort of broader consequences that follow. So that's by way of introduction. Some ground rules. We'll have Rayner go on for talk about maybe 20, 25 minutes, half an hour. We'll have a short discussion from Travis, and then we'll open up to a question and answer from our audience here. Now, for the audience Q&A, you have two choices. Either you can type it into the chat, I can read it out, or you can let me know, and I raise your hand. I will call on you, and you can ask your question by saying it out. Okay, those are the ground rules. I'm not going to take up any more time. Rayner, please take it away.
Thank you so much, Ian. And thank you so much, everyone, for being here. As always, I'm very nervous, but let me just try my best to not let the nerves take over. So I hope everyone can see the screen properly. And if not, please let me know. Feel free to just unmute yourself. Okay, so just very brief introduction. I'm currently a postdoc at the School of Public Health, where I did my PhD. Currently also a visiting scholar at Columbia University. And my research has been around substance use, sexual health, especially among sexual minorities. And today's presentation, I'll be focusing a little bit more on chemsex. So as a start, just some content warnings. I will be describing sexual activity and drug use. There will be some images of drugs. There'll be descriptions of negative traumatic experiences through the quotes of participants. These include stuff around like racism, HIV stigma, religious trauma, sexual assault, and so on. If you feel affected by it, do let me know. You can reach out to me via email and all that. And I do have some resources on hand as well. If you do feel affected by it. So those are my content warnings. So I'll start off first by talking about chemsex. What is chemsex? What is sexualized substance use? Just as a very easy way of doing this, this is actually a documentary called Chemsex. It was released, I think, in about 2015. It's about 2 minutes, so I'll just play it as an introduction to what chemsex is.
Stop, get home.
Are you in London tomorrow?
Yeah.
I'm coming to your house tonight.
Who's boy? Sexy boy. I'm taking alcohol, man. And what else? That's it. And what else? Methadone.
These days, you come into London to find your gay life, and you find Grindr. And within perhaps 4 conversations, you're going to be introduced to chems. Within 8 conversations on Grindr, you're going to be introduced to injecting or slamming.
Originally, sex and drugs were 2 separate things. Somewhere along the line, you were no longer having sex without drugs, and you were no longer having drugs without sex.
Tina, TG, they all mean one thing. It's time to party.
The feelings that you get is like a firework display in your soul.
It looks to some people like greedy, self-indulgent, promiscuous gay boys going out having fun on drugs. It's more complicated than that.
The gay scene can be such a lonely, alienating place.
The drugs gave me the confidence that I never had.
Vulnerable gay men with issues around sex, new drugs that tapped into that problem rather well, and changing technology. What they call the perfect storm.
Once you cross the line, and once you're in that world of chems and you're in that world of incredible sex, if you never come back across the line and see what else is there, it's very easy to stay in there.
Being diagnosed with HIV, so it happened after I'd OD'd on G.
5 gay men are being diagnosed with HIV every single day in London, just in London. That's a huge number. There's something about our relationship to our sex that's causing harm and that needs addressing.
Okay, so that's the documentary. I believe you can find it online. There's the trailer to it. So I mean, the tone and all that seems quite scary, right? You know, there's so much urgency in terms of its tone. There's so much stuff around, you know, it being a risk. And you know, I think chemsex in itself has come up as a so-called public health issue in the last like 5 to 6 years. So I think since about 2014, you started to see a lot of focus on this word chemsex come up in, you know, scholarly work in terms of the public health journals and so on. And it's largely stemmed from some kind of like urgency and alarm, you know, from the British healthcare system. And in fact, this word chemsex was coined around 2013 to 2014, you know, somewhere in the UK. This term has also been imported in the local media. So, you know, this is Channel News Asia, and it was also talking about, you know, how gay chemsex is fueling urban HIV epidemics, AIDS experts warn. Chemsex typically denotes the use of certain forms of substances combined with sex or sexual experiences. You know, these range across, you know, they in terms of the combination, they differ based on the different types of settings. So for example, in Singapore and the Southeast Asian region, you're more likely to get stuff like crystal meth, you know, amphetamine and a stimulant, along with stuff like gamma hydroxybutyrate, which is also short for GHB, which is known in some places as a date rape drug. But you know, these combinations do differ across different settings. You know, in the UK, you've got more, for example, methadone instead of crystal meth amphetamine. So one thing around chemsex is that it has always been viewed through a very pathological kind of lens, biomedical lens, right? You know, everything that's associated with this word tends to involve stuff like HIV, sexually transmitted infections, overdose, you know, trauma, disease. And you know, while we're not denying some of the harms associated with chemsex, you know, I think there is a risk of really going towards a direction that, you know, it stigmatizes or generalizes sexualized drug use in the gay male community. You know, some of the critiques of chemsex, and I think it's very important for me to cover, you know, the spectrum of different types of scholarship around chemsex, because, you know, to avoid really going into, you know, one mode of thinking around chemsex, right, is that you know, while chemsex as a word really came up maybe in about like 2013, 2014, you know, actually sexualized substance use has existed long before the word chemsex has come about. There are also critiques around how the term chemsex and the notion of, you know, risk associated with chemsex stigmatizes addiction narratives. So scholars have argued also around how you know, addiction biographies, especially those that, you know, suggest some form of addiction or drug habit, you know, they tend to paint people as defective, or, you know, they tend to have what they call ruin redemption types of narratives, you know, which does not really reflect the whole spectrum of substance use out there. There's also a risk of problematizing drug use, you know, and along with it, you know, problematizing the sexual minorities as well, and populations that are at risk of a substance use, or where substance use is of a higher prevalence. One other thing is also is that the scholarship around chemsex lately, at least, understates the benefits of drug use, whether illicit or not. So we often understate the pleasures associated with drug use, or the benefits associated with drug use, and that might actually sort of like pigeonhole drug use as a wholly negative thing. There have also been a scholarship, and I'm going to give a shout out to Tian Hui over here, because one thing that really inspired me earlier on in some of my work is seeing what public health scholarship would see as negative behaviors, such as smoking, such as the substance use or recreational substance use, as negative, as actually being very enabling experiences. So there's some good and some positive and desired aspects of recreational drug use that we should think about in terms of our approach to looking at some of these issues. While I say all that, because of my own past work and upbringing in the public health sphere, I think the work that I'll be presenting today does align with some of the public health perspectives and the lens that I'll be using. I'm going to share a little bit about past work and what drove or motivated this study. So at least in the public health literature, which I've been engaged with, chemsex also has always been talked about as a key driver of HIV and other STI in GBMSM, or gay, bisexual, and other men who have sex with men. It's been associated with HIV positive status in some of the surveys conducted out there. It's also been associated with HIV and other STI, or sexually transmitted infections, risk-related behaviors. Also, when you look at all the different surveys and studies involving people who engage in chemsex, it's been associated with mental health comorbidities, as well as poor mental health outcomes among individuals. When we look at qualitative studies, a lot of qualitative studies do look at the motives for sexualized drug use, in terms of sexual enhancement, its ability to alleviate the impact of mood disorders, alleviate some kinds of psychosocial stressors as well, the dread of becoming less attractive or unwanted. Some studies also look at how sexualized drug use provides a safe haven, from sexual discrimination and isolation for those living with HIV. But I think one thing that motivated this study was that a lot of the narratives around chemsex in the public health literature tend to focus on risks, tend to focus on what are more immediate kinds of motivations for chemsex. I think one thing around this was that we had some access to participants who were able to share more about their own life histories around substance use, and we were able to explore a little bit about what the role of social and structural drivers are in terms of underpinning chemsex, especially for GBMSM who are seeking treatment for substance use. Some past research that we conducted, I was very privileged to be part of a team with, now they are called NCID, or the National Center for Infectious Diseases, but they were part of Tan Tock Seng, the Institute of Infectious Disease Epidemiology. So they did a study on chemsex, and it was qualitative as well. This was a study involving 30 interviews with GBMSM in Singapore. And what they found was that overall, like for the analysis bit, these were all the different factors at different levels of a socio-ecological model that were driving chemsex in our own community. So at the individual level, you've got stuff like sexual enhancement, we've got peer pressure, we've got its use as a means of coping, and we also found different factors at different levels that all sort of point towards why chemsex might be prevalent. But I think these do not really address the life histories of individuals, which is what we wanted to do for this present study. So let me just go through a little bit about the methods for this study. This was conducted out of the Sociological Public Health in collaboration with the Greenhouse Community Services Limited. They are a charity in Singapore that focuses on providing substance use treatment and navigation for different types of services for people looking, or vulnerable communities looking for treatment for substance use. This study involved 33 participants, and everyone was recruited before circuit breaker. Thankfully, we managed to complete this about a month or two before things started to lock down here in Singapore. Participants were self-identified GBMSM, age 21 years old and above, purposively sampled. I'll discuss a little bit about what this means in the next slide. So we tried to get perspectives from a wide range of different demographics, to represent the narratives of maybe groups where it's important to get more narratives from. For example, in terms of ethnicity, while it's mostly Chinese, GBMSM, we really needed the perspectives from non-Chinese participants as well, because a lot of stigma, a lot of maybe discrimination, tends to affect sexual minorities and minorities within sexual minorities as well. Quite a number of participants, about a quarter, were ever incarcerated for their substance use. About a good, it's like 3/4 had ever sought treatment for their substance use in the sample, and about 13 out of 33 participants were HIV positive. We got a wide range of different religious affiliations as well. I conducted all the interviews except for one interview. They were all audio recorded, transcribed. After that, we coded in a team and we used thematic analysis to code. I will briefly share the different topics in the topic guide. We started to warm up a little bit to talk about perspectives around substance use, their own history of substance use. After that, we went into more of a narrative form to look at what happened in their own life histories around substance use, milestones in their substance use, key events, as well as maybe what was happening around these key events in their own lives. We also explored the role of HIV, as well as STI inside substance use and sexualized substance use behaviors. I think this was where the public health slant came about. One thing that I was super excited about was to ask about Chemsex, to ask about the venues in which they take place, how it happens, what are the different types of rituals and the norms associated with Chemsex. That won't come out so much in this presentation today, hopefully in a future one. And also we also focused on incarceration experiences, like what happened in prison. Also, what was it like in terms of reintegration as a GBMSM or someone who identifies as part of the LGBTQ plus community. So these were some of the different focuses for the topic guide. I think it's very important to talk about like my positionality and reflexivity for this study. As a gay Chinese cisgender man myself, I'm also a beneficiary of the greenhouse, and I have a history of substance use treatment and addiction. And we were recruiting most participants through the greenhouse community services itself. These have important implications for the type of data generated and the nature of the data generated in this study. So, on one side, it increases rapport, there's a certain kind of authenticity associated with the type of narratives that we get. People felt safe. For myself, conducting interviews, there's also a higher comprehension of implicit forms of expressions and certain sensitivities to issues. But on the flip side, I think scholars have also pointed out that approaching it this way, people with treatment experience tend to actually have some kinds of narratives that involve, or things were bad then, things are much better now. So these are what they call redemption narratives. So it might be biased in that way. There are also some limitations on the transferability of such data generated, through this study. But I think this is important for us to share, so that everyone here gets an idea of where we can situate this data in the whole spectrum of scholarship around Chemsex. So findings from this study, this is the framework that we generated through the findings. You'll see later some illustrative quotes for each of these different themes. So one thing was that around Chemsex, when we were talking about Chemsex with people, they were able to articulate that there were certain precipitants to Chemsex. And beyond these precipitants, which are things that sort of precipitated or preceded immediate use, a lot of people also were able to articulate, participants were able to articulate how some forms of complex or acute traumas were actually exacerbating or had underpinned such forms of precipitants in their lives. Beyond that, participants also were able to sort of illustrate, beyond the traumas, there are some preconditions, in our context, in our society, in our legal framework that sort of underpin such forms of trauma and precipitants, or also sort of serve as like barriers to addressing Chemsex in their own lives. This is definitely a more pathological view of what Chemsex is, but I just want to sort of focus on, these are the experiences of a largely treatment experience sample. A lot of them have sought treatment for substance use in their lives, and there is, I caveat and have a disclaimer, a positive side of chemsex that they also were able to articulate, which I won't be covering in detail unless you ask later, because I got some hidden slides. Okay, so for precipitants, these are some examples that participants talked about. They talked about how chemsex or engaging in chemsex, helped with emotional wounds, loneliness. Someone talked about how I have no one to talk about my problems. So I felt that the drug was a person who was like my counselor. When you take it, it kind of feels like you fix everything temporarily. You put a balm, you put a band-aid on it temporarily to not let it bleed. In terms of loneliness, someone mentioned that I remember I felt very stuck in my job and my life. There were many factors, but at that point in time when I started using, I felt very, first of all, very alone, very lonely. And at the interpersonal level, emotions came up, feelings came up, and that were maybe like uncomfortable for participants. And chemsex and engaging in chemsex help participants deal with such forms of precipitants. So for the first one on sexual shame, this participant was talking about how I'm not comfortable with my sexuality in bed. So having crystal meth definitely made it a lot easier for me to just enjoy the process rather going like it's wrong, or being uncomfortable about it. In terms of social connections as well, it also helps people feel like they're able to connect with other people. So this participant also talks about how it is very hard for me to connect with people when I'm sober. That's for the second quote. Apart from individual or interpersonal level types of precipitants, we also found sort of like external stressors that could serve as precipitants. So these were general, for example, work-related stress, financial and family-related stress, which I'll not go into detail over here for the interest of time. When we talk about trauma, these were largely, what we also call complex trauma. They might not be acute or individual events that are traumatic, but it could actually be exposure to longer term traumatic events, which I believe the technical term would be complex traumas. So these include, for example, HIV related stigma and racism. So HIV related stigma, one example, someone shared, as a chem user, when I got diagnosed with HIV, it only led me to being much more underground. It was already difficult, but drug use does feel liberating. When I got positive, it became like I wouldn't say it's a need, but it became the only place where I could be myself. In terms of racism, they go like, what race are you? Are you Indian? Are you local? It's like, so what if I'm Indian? So how does my picture define your sexual preference regardless of my race? When I'm clean, these comments really bog you down. Not at the moment. Under the influence, I don't care. I just don't care. I say something nasty back and just ignore. So these are intra-community sources of traumatic experiences. In terms of general society, we are looking also at stuff like homophobia. Someone said that it's not because I'm gay, that's why I have mental health issues. It's because I'm gay in this society and it comes with certain stresses, and that's why I have mental health issues. I've been in situations where I've been denied help, medical help, or they were not as professional because of how I look. They treat you differently. And when it comes to religion and religious trauma, this participant was talking about, I think religion is also very tied to my sexuality because I've known for a very long time that I'm gay, but I always had to repress it very actively, just like in my femininity and the way I express myself or my attractions. I read a quote recently, which is like, queer people don't actually have the opportunity to live as themselves when they were young. We could never be us because all these internalized traumas and all these external factors repressing us, oppressing us. So I really vibe with that because I came from a very staunch Christian family. Also, general neglect from family. Someone talks about how he came from an environment where mom was working long hours. He didn't really have assurance when he was young. Didn't have that much advice growing up. It started out as sex to make me feel better. When it became chemsex, it literally became sex on steroids, so it's even better. There are also sort of acute traumas, discrete incidents such as sexual violence that that sort of serve as traumas associated with chemsex. So I had to go to the A&E. They asked me if I wanted to do the rape thing, and I refused because there would be drug tests involved, so I didn't do that. It took over 3 weeks for me to recover from physical injuries. I was intent on killing myself. I'm like, the only way I'm going to survive this is, I have to take my own life. So I signed up for rehab in Thailand without even knowing, what I was going for. Next, death and loss also served as a discrete incident that sort of was traumatic for participants. When we talk about preconditions, we're actually going further up, in terms of the types of social, structural, and precipitants. So we have also normative aspects in the community. The fact that accessing chemsex is easy. So people talk about going to Grindr, being able to get stuff on Grindr easily. There's also this idea that chemsex is sort of like a norm in a community. People perceive that there are quite a lot of people in the community using it. There are different types of users, and they think that a lot of people would probably have tried it before, but they may not talk about it because they feel like I'm not a hardcore user, so it's a non-issue. Beyond the normative aspects, there's this idea of a sexual capital as well. So I think there's this idea that participants were able to articulate around how sexual attractiveness, define their own self-worth. So one participant was talking about, is drug use a problem? I think it has always been a problem in the gay community of our own. Escaping from our own discrimination, it has always been probably how we've dealt with it. We've not been very good avenues to support each other. So much of our community is based on youth, that the older ones, they feel left out, left by the wayside, they felt discarded. There's definitely no support there. It's more a symptom. So drug use is a symptom rather, someone just threw a bunch of drugs at us and we flocked to it like magpies. Someone else also talked about how, I do see certain patterns that fuel this problem. For example, an aging gay person may feel that his self-worth is diminishing because our community places a lot of emphasis on someone's appearances. And associated with this was the idea of there were a lack of safe spaces. There was a lot of sexualization and hypersexualization of people's formative experiences because of the lack of safe spaces. So, for example, in the first quote, someone says that when you are young, you see being gay as shameful. So, and that's a very formative period where you're building your character and your personality, and you're still going through so much. Also, for me, when I came out, I was just rampantly having sex because I could. I wasn't like I needed to have sex, but it was just something that, oh, I'm gay and I therefore should become slutty kind of situation. The second quote over here, sort of aligns with this in some way. The person says that, when you are raised in a community and a society that either says you are wrong, you'll be punished, it's illegal, the stigma around the fact that homosexual sex is still illegal, creates shame. And with regards to, certain drugs, even alcohol, they can be extremely liberating, particularly for someone who is trying to discover and understand their own sexuality in a community where information about it is not generally or freely at hand, whether from educational sources, community support sources, or otherwise. Overall, there's also a lack of formal support, which also privileges sexualized substance use as a form of coping for some of these participants. So in terms of those who have been incarcerated, they report no LGBTQ-friendly aftercare. There's no aftercare support. Once you finish your tagging, they just let you go. There's also a lack of family support in general. So let's say when participants encountered issues, they found it difficult to talk to their families about it, especially for their families who did not know about their sexuality. So your family who don't know about your sexuality and there's some problems at home, you can't explain to them and you just want to forget what they say. This participant was talking about. There's also a lack of legal support that sort of serve as a precondition as well. So, once I decided that I'm going to live up my life as a gay man, I think there are certain structures that aren't in place for a gay person that will be reassuring for someone growing old as a gay person versus a straight person, such as marital laws. They also refer to the penal code as well for this lack of formal support. Finally, one precondition is definitely the barriers to care for substance use treatment. There is a perceived lack of available help. Back then when someone was trying to recover or seek out substance use treatment, they perceived that there wasn't much help openly available for you to go for. There's also a lot of stigma around drug use in general in Singapore. I did go through a community-based organization, and one fine day I just asked a lot, are we going to do anything about the chem issue? And I was hushed to silence by other members in the community. So this is something that people learn not to talk about. And this person kind of got disillusioned. There's also a very strong fear of being reported for talking about their own substance use experiences. So openly, they're afraid to talk about it in terms of seeking help to maybe a professional, a medical professional, or even a counselor. I was told that even counselors are supposed to report you to drug enforcement agencies if you have problems with drugs. That's just part of the rules and regulations. This is a perception of one participant. Another participant was talking about, am I going to get caught instead? If I go and seek help, or is there sufficient support in whatever format it would be to support someone like me? So these are some of the preconditions that prevent participants from really dealing with chemsex in their own lives in a very constructive way. So as a means of discussion, this was the framework that I introduced initially. Some of the quotes you have actually seen, and we can actually see how these different factors at different parts of their own life histories as well as in society. Sort of privilege chemsex as a form of coping, especially for GBMSM who are treatment experienced and who have sought treatment for their substance use. This I would say that is not reflective of generally everyone's experiences of substance use or sexualized substance use in the community, because there are people who report actually using it in a very a beneficial way for them in terms of sexual enhancement. So this is definitely one slice of the experiences and lived experiences for GBMSM, and it has certain implications for treatment as well when it comes to substance use. So when we look at this conceptual framework, it allows us to see where different types of interventions may be available for people who are looking for treatment for substance use. So in terms of preconditions, we see stuff like the laws like Section 377A, Misuse of Drug Act, and also even for the SMC, Singapore Medical Council regulations around reporting a suspected drug user. These are all things that prevent individuals from really learning more about their own substance use and their relationship with substances, as well as seeking help for substances, if they need help. Also, I think this is very important for treatment and counseling and therapeutic experiences as well, because for general substance use treatment facilities, for example, they need to be well informed about the types of traumas that are culturally informed and are specific to different types of individuals and communities as well. So these would definitely translate into maybe peer support systems, LGBTQ plus specific services, as well as trauma focused therapies. Because I think as LGBTQ plus identifying individuals, it is reasonable to assume that there are potentially more forms of complex traumas that someone might experience throughout their lives. Trauma focused therapies would be something that a therapeutic service would be offering them. Also, it translates to education and advocacy. There needs to be more information on resources and literacy around substance use and addiction. Right now, we only see sort of like a binary: it's illegal or legal. But then that's on one end. Legality does not discuss about morality around substance use, and morality does not imply anything about whether it's pathological or not. What we know from the literature is that there is a spectrum of substance use and different types of experiences, and different people have unique relationships with substances as well. When we talk about maybe our own economic policies or even our political philosophies here in Singapore, like Prof. Kong wrote a paper on the neoliberalism in Hong Kong and drug policies. Likewise in Singapore, we have also a very strong health policies around self-reliance and non-welfareism. So in this kind of context, addiction is often framed as a failure or deficiency of self, and also a lack of recovery. It's also framed as a lack of self-will. You never took that trampoline to take the jump towards your own recovery. So these are some of the stigmatizing narratives that might actually happen in these kinds of economic and political philosophical contexts. Also, this meant that a lot of non-welfareism led to this many helping hands approach. Only sort of the worthy get funded, by government agencies. So, for example, we know from the past universal periodic reports that there have been a lack of LGBTQ plus organizations that have been registered as charities. And I think the lack of funding in this area also has exacerbated service and treatment gaps for LGBTQ plus identifying individuals. Also, the criminalization of drug use, and gender stigma towards drug use. There's a lack of literacy, because all use is wrong. And this has implications for barriers to care as well. Lastly, I would just say that I want to share that the data generated here reflects just a small portion of the lived experiences and worldviews for GBMSM who use drugs. These are all treatment experienced GBMSM. It does not reflect or the wider community's experiences, and we don't want to stigmatize substance use for those who do not have a problem with it. But I would also caveat that and say that in a context like Singapore, a lot more discussion around this probably needs to be nuanced as well. Because when it comes to treatment for substance use, while there is a recognition that there's a spectrum of a substance use and there's a spectrum of relationships, it is all happening within this context, blanket context where it is illegal. So whether it is problematic or not, there's also depends on who is labeling it. You know, for an individual, it might be different, you know, but within this context, it is labeled as illegal. So these are all considerations for treatment services here. Yeah, that's the end of my presentation. Just some acknowledgements. You know, I really want to thank the academia.sg team, you know, for their support and for this opportunity. Prof. Kong, Prof. Chong, Prof. George, Corey, and the rest of the academia.sg team who have been working with me to get prepared for this presentation. Participants for this study, the greenhouse, you know, especially all the other LGBTQ plus community groups who helped share, you know, the recruitment message for this study. NUS IRB, whom I worked with, you know, quite a long time to get the protocol approved, you know, and you know, really benefited from their own comments and suggestions. Collaborators, you know, Alaric, David, Krish, Eleanor, Liping, Dr. Maha, and you know, contributors to this study also who helped with the interviews as well as the transcription, Meishen, Daniel, and Brian. With that, I end my presentation. Thank you so much.
All right, thank you so much, Rayner. And now, if you could end your screen sharing, I'd like to turn things over to Travis. Please take it away.
Oh wow, amazing! Like, you know, because when you sent to me your PowerPoint, you know, with like so many PowerPoint slides, I didn't know that you can actually finish all of them, you know, within like 30 minutes or so. Like, yeah, so congratulations. And I really enjoyed it. Like, I think there are 2 points I really want to point out. The first one is like your use of qualitative study. For me, it's really crucial and important because like the whole public health paradigm is actually dominated by quantitative study, right? Using survey and questionnaire. I think like, you know, they of course have its own merit in the sense like they can sketch out like the more general pattern of this risk population, so to speak, right? And then trying to examine the correlation of the various like risk factor and most likely leading to like HIV and AIDS prevention. But then like, you know, those kind of study always kind of like lack the in-depth analysis, you know, and then what you have done for me is so important and crucial is the way that you use life story, you use that kind of like, you know, narratives. And so in some way, you actually really help us to know more about the voice of these young, well, not really, or these like, you know, GBMSM, like their struggles, you know, their fears, their problems, their pleasures and everything. So I think this is something that is, I really enjoyed it. It's the way that you actually really tease out the life experiences of how these men actually really experience, you know, their struggles, their worries, their fears, and also the ways how they cope with that. So yeah, this is the first thing I would like to comment on, and I really appreciate that. And then the second one is the way that you used what you call your framework, like the preconditions and then trauma and the precipitants, right? You know, that kind of like model to think about it. I think it's also intriguing, you know, because it's the way that you not just talking about more a psychological aspect of these individuals, but you're more to trying to link the interplay between these individuals with the wider community and then the society. From there, like we can actually not just seeing the struggles of this man who actually like engage in chemsex, but also understand more about their motivations and also about the way that how they actually access to the setting, right? So you talk a lot about like the setting for like, you know, the chemsex that actually could happen, and what I find more interesting is the way that you talk about like how they engage with like different preconditions, in some way talk about different kind of like communities. I think the community you said it quite clear. Like there's actually 2 different types of community. One is the gay community, right, where they actually encounter like discrimination, stigma, and all that. But also coming from the wider strict, you know, the wider community, the strict community, the way that how discrimination and stigma actually enforced. And then the way this, you also talking more about like the mental health system and also the legal system, and how in some way they actually like embedded, you know, in this individual's life. So I think this like, you know, really enrich our understanding about these individuals. And so in that sense, like we can actually know more about the socio-economic and even political and legal context to shape the whole chemsex experiences in Singapore. So these are the 2 really great things that I articulate, and I really appreciate that you done it so well. And I also have like some question that I would like to engage with you. The first one is like because in some way you kind of like still very much into that like trauma-informed framework, right? Under the whole public health paradigm. So in some way, I'm really curious about your title. Your title is what? Like it's Chasing Utopias, Chemsex as Liberation in Gay Singapore. So in some way, what you have said seems to be the opposite of what you propose in your title. So I really want to understand and know a bit more about, from your point of view, how could we actually understand Chemsex as a utopia? How could I understand Chemsex like as a liberation? Okay, so this is my first question. My second question is like I enjoy so much about like your qualitative study of like this GBN and MSM, but I also wondering like how we can actually in some way trying to go beyond that, and then we can actually tap into more sociological debates and discussion. I don't know whether you heard about like Stephen Lim's idea about edge work. And he talked about the idea of edge work. Originally, he talked about the way how people engage in some voluntary risky behavior, like skydiving, car racing and all that. And then he trying to talk about the way that how people trying to balance risk and pleasure by negotiating boundary between order and chaos. So in some way, like, Chemsex could also be understood as a leisure edge work. Okay, so this is something that maybe you could think about. And also I find like, Chemsex is so different from other activity or even sexual activities among GBNFM. So for example, like, they actually create a very interesting chem space, right? I mean, the space that they created to have Chemsex in some ways very, very different from other like gay spaces, like you go to a public toilet to have a public sex, or like you go to gay sauna, or even if you go to bars, or even if you go to like a circuit party. So it seems to be like Chemsex represents something quite interesting and quite unique in terms of the way that how they create a new space for these men to relate with one another. Okay, and then apart from space, the other thing is about relationship, right? Because I think nowadays, as like we talk about the whole neoliberal, kind of like nurturing, like so the traditional idea about gay man and lesbian, has always been seen as like pathological, criminal, sad, closeted, but now we kind of like shift a little bit, right? And then we focus so much, and also the image actually been changed to be like, oh yeah, you could be gay, but then you could be like, more a responsible and respectable good sexual citizen, right? I think this kind of like whole shift is actually really happening in most of the societies in the world. And so these like, gay men engaging in Chemsex in some way, they actually envision a very bad sexual citizen, in some way, like, they are like a carrier of like triple discrimination, right? They're gay, and then they are into Chemsex, and also most of them are HIV positive. So they're actually triply like stigmatized, and also they engage in some kind of like intimacy, which also contradict with our normative idea about relationship or intimacy, right? And ideal relationship usually talk about monogamous, like in one-to-one, long-term, and also in emotion. But then, like when you engage in Chemsex, you in some way violate all these kind of like rules that govern an intimate relationship. You will be seen as promiscuous, like in group, and also like maybe transient and only focus on sex, blah 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 blah. So in some way, like I think they actually engage and also envision a very different form of like intimacy, but then we might in some way have to acknowledge what that form of like intimacy is about, and how can we actually really reconcile it, and so this is the second major thing I would like you to maybe you could share about your opinion on it. And then my third idea, or not really comment, but my third point I would like to articulate is more practical, because in your presentation you didn't say too much about it, but then like I'm sure like you have a lot of ideas on it. It's like how can we actually really help this man is at risk, right? And then like how can we actually imagine and also envision like harm reduction under the criminalized approach or under the criminalized framework, especially like, you know, in Singapore, right? I mean, if you ask them not to take drugs, I think it's quite impossible and not realistic because they were still doing it, right? And so how can we actually ask them to use it, like, you know, in a more safer way, you know, and also in the way that how they can actually like take control and also understand about, you know, the warrior risk that they're actually encountering, and in what ways like we can actually provide different kind of like intervention, like strategies, you know, to help and also enhance the well-being of these individuals. Okay, so this is like, you know, my very short like, you know, comment and feedback to your really wonderful presentation. Thank you.
Hey, thank you so much, Prof. Kong.
Wonderful. Thank you very much, Travis. Rayner, I'm going to ask you to hold your thoughts for a second. Because of the timing, I think we should go to the audience.
I'm sorry, like
no problem. It was great. I think both the presentation and your discussion was wonderful. So right now I see a question from Ritu Jain. Ritu, would you like to read your question out online, or would you prefer me to read it out?
I'm happy to. Thank you so much, Ian. Ray, it was absolutely an eye-opener, and as a novice to the area, this is fascinating about the underbelly of the country we live in. I would like to know, when you talked about things like what the barriers on accessing services, social services like social support systems, on how to overcome addiction. If I'm phrasing it correctly, I was wondering if transparency or clarifications around confidentiality between support systems and clients, it could be made available, that this is a criteria, assuming that this is a criteria. And if samples of these documents could be made available at support networks or sessions that are held informally or even formally at organizations that you regularly volunteer and work at, whether that would help in addressing that kind of behavior. It seems like a very small thing, so I'm a bit confused about why this isn't happening.
All right, Rayner, would you like to respond really quickly, because I don't see any hands up or any questions yet. Please go ahead.
Okay, so I would say that there is a certain kind of tension between how we have a zero tolerance policy around substance use, which also has translated into maybe certain kinds of regulations, and when I'm talking about the Singapore Medical Council types of regulations, they actually apply to doctors, but then it is unclear whether it applies to maybe other forms of healthcare professionals such as counselors or social workers as well. So I would say that there is a lot of perceived fear around approaching people who seem to be a part of maybe an institution, and therefore that perception alone is a barrier, and also the experiences of other people who have been through this might be shared, and that might be a barrier.
Okay, so I see Christian Moeller has his hand up. Christian, would you like to ask your question?
Yes, thank you. Hi, Rayner. Thank you for an amazing talk. I also work with Chemsex, more like mediated aspects of it. And I was wondering, so these are fascinating questions that came also. I would love to hear more about the generative and kind of like the usefulness aspects that you hinted at in the beginning. But maybe more specifically, if you know, well, in terms of maybe Jamie Hickham's work, if you're familiar with, where he talks about in this article about, he looks at the Chemsex as kind of like in post-financial crisis London, and he does this conjunctural analysis where he kind of shows how it's certain kind of effective registers and sociability that make sense within this form of self-entrepreneurial life that you need to do within this space. And I was wondering if you have any reflections, like based on your material, of that analysis, if it speaks to you, or kind of like how you go about that. Thank you.
Thanks so much, Christian. Sorry, should I?
Please go ahead.
Oh, okay. To be very honest, I have not given it much thought, and to be, I guess, very upfront about my disclosures. We had approached this from a very biomedical kind of approach, for this particular study. Which I admittedly, one of my goals for today is to really engage with scholars in non-public health kinds of settings, to be able to have discussions around like the different forms and ways in which we can sort of make sense of chemsex. For me, I think that's my very uninspiring response to your question. But I wish we can maybe like have a chat about this in depth, because I have come across Jamie Hakim's article and also his interviews with, like, for example, Kane Race and other scholars in the field also. And I would love to hear your thoughts on it.
All right, so I've got two questions, one from Zihan, who is one of our previous presenters, and also Jonathan Tang. Zihan and Jonathan, would you guys like to raise your questions, or I can read them too if you prefer? No. Okay, so I'll read their questions. Zahan asks, I'm interested in asking whether you could share a little bit more on the process of IRB, specifically thinking about the production of knowledge for the neoliberal academy with the trappings of neoliberalism that you highlighted. This is an important and necessary study, especially for the community to initiate conversations. But I'm slightly anxious about the knowledge we produce as native informants being misappropriated by the institution in the ways that we do not predict or desire. This is an anxiety that I negotiate with as I research on queer resistance in making the illegible legible to the academy through theory. How do I protect the subjects of my study, particularly within political conditions that have a strong historical track record of crushing dissent and difference? How do we code our research in ways that might be able to that might be legible to those who need and seek it, while illegible to those who intend to extract in appropriate and insidious ways? Jonathan's question is, he says, thank you for your wonderful talk. I really appreciate your research methodology and how you reflected on your own positionality and how it can facilitate or impede the research process. I was just wondering if there was any transference and countertransference that occurred during your research process. If you are comfortable to share, that would be great. On another note, I'm curious about your thoughts on the next steps for the study. How will your results inform government policy, or what does this mean for society and social change? Oh, I'll add Yoyan's question because it's quite short. She's curious to hear your response to Prof. Kong's first question regarding your title referring to utopias and liberation. Could you say more about how your findings relate to these? Okay, we'll stop here for now.
Okay. So I'll answer the first one, because this was something that I sort of reminded myself to talk about before the talk, but I didn't manage to say it when it came to the framework. But I think the reason why we talk about chasing utopias, comes from sort of like what I thought of, and of course this is a very biased kind of interpretation of it, right? Based on my own experiences also, that coming from a very dystopian kind of existence or worldview, right? Like where there are certain kinds of stresses that are underpinned by certain kinds of complex traumas as well as acute traumas, and living in a kind of setting that doesn't really allow for the the escape from such forms of trauma. A lot of narratives point towards how substance use and engaging in sexualized substance use was a means of liberating oneself from all these forms of pressures that are weighing down on an individual. So I saw that as sort of, in a way, chasing utopias, because these experiences are often articulated as maybe sometimes fleeting, sometimes always that utopia is elusive in some way. And at the same time, when I talk about liberation in Gay Singapore, the Gay Singapore would be some of these social structural drivers towards chemsex, and liberating oneself from it through chemsex as a means of it. I hope that answers the question. Also, maybe I'll move on to Hans' question. I think this is a super really good question. I thank Zhan for it. I think the process of IRB can be a bit tricky. I've never had like anything less than a full board review for some of the work, but I think there are two sort of like sub questions here. The first one, I think protecting participants has also been sort of a goal of the IRB that I work with. I think part of it really involves getting a lot of community groups involved as well. So for example, in this particular research and other research, I definitely try my best, not to be the one to, gather contact details. If anything, it will be done by a community partner, so that and also the data that is generated from this study is shared with the community partner in sort of an aggregated or anonymized form. So we never really match the data generated together with participants' contact details. So I do also note how some of the data generated also tends to get taken out of context. At least for me, one fear that I have around even for today's talk or any talks that I give is that the data that's shared out there will be misappropriated or shared out of context. It could be politicized. I don't really have a very maybe satisfying answer to this, but for me, at least personally, I do check in with members of the community, as well as I do try and frame different aspects of the data in different ways, depending on the goal of the talk and who the audience is. I think that's the way that I try and navigate it. It might not be perfect, but I think I do still have lingering anxieties around the idea of dissent as well. Maybe you can, if you have any follow-up questions, please let me know. So for Jonathan's question on research methodology, transference and counter-transference, I think I share this on a more personal level. After sometimes doing a couple of interviews, I really need to take a break myself. Maybe 2 weeks, 3 weeks, and actually not being able to do any further interviews because I really feel for lack of a better word, I feel super duper down. And after conducting some interviews, and I think part of that reflective process, was really reflecting on the interview experience that I just had, and really asking myself about are my emotions affecting the way that I'm interpreting the data? Because as part of my training as a qualitative researcher is around some of these aspects, right? Around how managing my emotions, managing my own biases. I as a researcher, I don't believe in fully bracketing my own emotions. Some might argue for that, but I don't think I can actually become a robot throughout my own qualitative work. So I think for me, the way I manage that is to really acknowledge what I'm feeling, acknowledge what comes up, and then dealing and responding to it appropriately. So I think also next steps. This study was actually conducted with a community partner, and I think the most immediate need that we saw in the community, and this also informs my approach and the biases that I have, right, was that when dealing with substance use among at least GBMSM, where we never really had much to actually start off with in terms of data, in terms of structures, how do we approach things? And I think one thing that came up inductively through a lot of case management done at the community group level is that participants really, or rather clients really shared histories of a lot of traumatic experiences, and these could be complex traumas, acute traumas, and a trauma-informed framework has been used in different types of therapeutic settings. I think it's quite a sort of productive kind of approach to addressing substance use for those who need extra support.
Okay, so I'm just going to end off because the presentation is a bit long with two questions. One from Paul Jerusalem, and one of them is mine. Paul says he wants to add on to ask if there's anything to do with Cruising Utopias by Jose Esteban Munoz. And my question has to do with this. A lot of your description so far sounds actually very middle class or upper class Singaporean, right? Being able to book rehab in Thailand, for instance. But you talk about race and religion, but you never really dealt with the issue of class. How does that actually feature in your study?
I think that's a very important question, and probably a blind spot as well, for the way that I see it. I think a lot of the participants also were mostly like at least bachelors and above. I think probably in terms of sampling, we were not able to reach, participants who really maybe could provide narratives that reflect the impact of class or the relationship between class and their using experiences. But what I would actually think about is, there would be an effect of class in terms of accessing healthcare services, in terms of maybe certain forms or impacting certain forms of perceptions around stigma, as well as what else in terms of okay, sorry, I lost my train of thought. But the next thing I wanted to focus on is that I think especially with work and sexual minority groups, we don't want to also say that class impacts your experiences this way, but we really have to maybe as a next step look at like intersectionality as a lens. I would say that for example, I talk about how race impacts chemsex. I talk about how HIV stigma impacts chemsex. But what about someone who identifies with multiple, intersecting identities? The experiences are compounded, experiences are unique, and the pathways to treatment and the kinds of the stressors involved in that will be very different. But I acknowledge that definitely didn't really cover how class impacted participants here.
Right. Do you want to address Paul's question?
Yes. Okay. So I thank you for that. I actually will check that out because it was not intentional to reference Cruising Utopias or by Jose Esteban Munoz.
Okay.
Yeah.
All right. So given that we're a little bit over, but that's okay. Do you want to sort of quickly wrap up? And if Travis has any sort of final comments, we can do that, and then we can wrap up. Do you want to respond to Travis, for instance? Go ahead.
I think one thing that I did not get a chance to respond to was Travis's, I think, second or third comment about the different types of maybe sociological contributions and perspectives towards this work. I think one thing that I have been very much away from, and I haven't really been able to access is maybe sociological thought or critical theory, and thinking about chemsex through those lenses. I think something that's really exciting would be being able to collaborate with anyone here, anyone who's interested in chemsex or sexualized substance use, wants to really try and really expand the scholarship on the different diverse forms and unique forms of using. I think that not only has scholarly implications and contributions, but from, I guess, a service provision perspective, from a healthcare perspective, from the perspective that we should optimize pleasure even. I think these all are important aspects of I guess human experience, right, and to alleviate suffering. So I think really I would love to work with more scholars on this. Yeah.
All right, wonderful. Any last comments, Travis?
No, not really though. Like, maybe I'm thinking like instead of talking about chasing utopia, they might be chasing dystopia. Yeah. But no further comments. Thank you.
All right, wonderful. So I'd like to really thank Travis for putting in all the work, reading, and answering my cold call on the email to be a wonderful discussant today, and Rayner, of course, for stepping up and doing this really great presentation. I think I learned a lot, and I hope many of the participants here did as well. So that brings us to the conclusion of this installment of our Academia SG Junior Scholar Seminar. And for those of you who would want to see this on video, it will be available on YouTube in a couple of days on the Academia SG channel. And otherwise, I would like to thank all of you for attending, and please do watch out for our next installment of our Junior Scholar Seminar. Thank you all. Have a good evening and enjoy your Friday and weekend.